Hey guys, we're going to talk about strabismus today. So I titled it, Can You See in 3D? I posted the other day asking the same question, and I got a couple results. So I told them to stay tuned for this video. There was actually a really interesting article that came out in the Optometry, I think, magazine, and it was talking about the surge in children, adolescents, and even adults really going to the eye doctor after they had been to 3D movies. So they became popular again like 10 years ago, maybe a little bit longer. And the eye doctor started seeing so many more cases of people coming in saying, "Hey, I can't see in 3D. I just realized this when I went to the movies." And, it's wonderful. I mean, I can't see 3D, so I never have really liked it. I can't see it, and then it makes me sick, so I'm just not into it. But the fact that it's bringing all of these people to the eye doctor that probably would never been because they think that they can see perfect is amazing, okay? And if you haven't noticed by now, I am a little bit obsessed with vision help. Eye help, anything like that. So I am all about getting the message out any way you can. So if the way that you can get it out means, hey, you know what, go see a 3D movie. Cool. Just get the message out. You know what I mean? So strabismus means your eyes don't work together. Binocular vision is working together. So if you look through binoculars, right, you can't see through those like the normal person. I've never been able to look through those normally. I've always had to close an eye. If you use a microscope, same thing. There's a microscope head on a slit lamp that the doctors use when they do your eye exam. I never could use both of those. You either have to close an eye or basically your brain tunes out the other eye. So binocular vision is what you do not have, okay? Your eyes don't look in the same direction at the same time. Now, that can mean one eye is affected or the other eye is affected or both eyes. And now when I say the other one, I mean that it can change sides. And it is a brain issue mostly. Obviously, it's an optokinetic, an eye issue, because that's what you're seeing the issues with. But it starts in your brain. Your brain waves your eyes send back 2 images. In your brain, it comes back as 1. Well, ours don't. So you can either, it depends on how long you've had it. If you get it at onset as an adult, typically that's when you start having diplopia or double vision. And there's things that you can do about that. But for kids, they almost always just have single vision. They do have issues with focus and things like that, but the diplopia, we have learned over time as adults how to receive information into the brain, and we're used to, if you've just got it as an adult, we're used to receiving 2 images. Well, as a kid, their brain isn't used to that, so basically what happens is it completely tunes out the other eye. So instead of seeing those 2 opposite images, you're just seeing the one. So the problem is, if you don't get this treated and fixed pretty quickly, you start getting what's called strabismic amblyopia. So what that means, amblyopia means that you cannot correct your vision to 20/20. No matter what you're doing, cannot do it. Obviously, I have that too because I have like every eye issue, right? If you guys are commenting, I can't see it for some reason, so I will get back to you and address that if you are. or if you have questions. So what happens is they tune out this other eye. Well, the longer they tune out this other eye, the weaker that eye gets, because your eye has 6 muscles, right? It has, kind of looks like a star, if you will, around your eyeball, because you have the 2 up here, and they control how you're going up and down. You have the 2 side to side, it controls side to side motion, and then you have the angles, and that helps you get the rest of that circle that the other 4 muscles aren't controlling. So, there's different ways that the eye can turn, and I'll give you a couple different examples. What you know is cross-eyed. The eye turns in, and that's called esotropia. Tropia means turn. Okay. I don't really hear it very often anymore, but wall-eyed, that's out, because you're looking at the wall, and that's exotropia. And then there's up and down, which is less common, actually tremendously less common, but that's hypertropia for up and hypotropia for down. And the reason I like to tell you these medical terms is because when you're in there getting an eye exam, and I'm guilty, I've done it. As much as I hate when they do it, I've done it. When you're looking through the slit lamp as a medical professional, you have this checklist that you have in your head, and you're wanting to check off as you see it, right? So as you see it, you start going, and if you have someone over there doing dictation for you, you'll say something like hypertropia. Well, as a patient, you have no idea what that means, and most of the time, most patients don't really care, so they don't look into it. But I'm hoping that if I teach you guys some of these medical terminology words, that you will be more apt to maybe ask questions or look it up, or at least know what they're talking about in a roundabout way, in a direct way, anything. My baby has that. He looks at, exotropia. Is it both eyes, or is it, does it switch? Is it constant? That's another thing I was going to touch on. The accommodative esotropia, that means that it's not in all the time. Okay, so most of them are constant, that you notice, because there's, what is it called? Large and small angles, because they judge the turn by using these little glass things, not the ones that they choose your vision with, but they have like they're thicker at one side and they're in a triangle. No, it's not all the time. Probably when he's tired, I'm guessing. Tired, angry, stressed. It's usually when that, and like the other day, the nystagmus, that's when that gets worse. What was it? Oh, the angles. So they measure how far it is. And for people with large angle, that means that that's that person that you look at, and I mean, I'm just going to say it, you feel uncomfortable because they don't know if you're looking at them, if they're looking at you, you know, because they're like, you're looking and you're like, okay, which eye am I supposed to look at? I mean, I'm just being real. I practice tough love, and I'm sorry if you don't like that, but that's kind of me. So the small angle is when people just have a slight turn, or like in Elizabeth's case, her kid has, it's not constant, it's intermittent. And it can change sides, like I said earlier, it can change directions. So sometimes you might have the turn inward, sometimes it might be outward. Now that's not as common as it going the same way each time, but it can happen. Okay? Some surefire signs that you see. Obviously, the large angle, you see the turn. With the bad eye, a lot of times when they get in sunlight or fluorescent light, they will cover it because it's weak, right? It can't accommodate, and it can't constrict and dilate like the normal eye. So they cover it. It's an accommodative measure, right? It affects your depth perception really, really bad, right? I mean, I have a lot of things that affect my depth perception, but this is definitely one, because, you know, if your eyes aren't working together, depth perception is that one image that you can judge, right? If your eyes don't work together, you cannot achieve that, okay? Which really sucks. I don't know how many of you have depth perception problems, but it is a pain in the you-know-what, because, I mean, let me just give you an example. When I'm in the passenger seat and someone else is driving, and they are getting ready to turn when there's an oncoming car, I have to close my eyes, or I just completely freak out, because I'm thinking, oh my God, we're going to die in this fiery accident, and that's all she wrote. Well, then they make the turn, and I'm like, oh, okay, well, we're still alive, right? I know that seems really, really silly, but if you do have depth perception problems, you know exactly what I'm talking about, and I don't seem like quite as crazy as I'm coming across to those who have great depth perception. And I will tell you, that is something that you need to treasure, because it's something that you have to work constantly at if you do not have that. Even like parking, driving is probably the hardest. It's the most noted. But I'll tell you a funny story. When I was in church camp, when I was probably high school, we had to play a game every day, or a sport, or whatever. So me and my friend picked volleyball. And I generally tried not to pick any type of ball sports, because I knew that my depth perception was bad, and, you know, things like that. So I just didn't, right? Well, I guess we'd signed up later, and there wasn't any options. So we got stuck with volleyball. And so I was in the very back, and I thought, okay, if the ball doesn't get to me, then I don't have to worry about it, right? Well, I guess there must have been someone on the other side that was really good or something, because the ball came to me, or so I thought it came to me, and I started swinging at the ball, and the ball never came. I never touched the ball. So everybody started laughing, and, you know, I luckily I've never really cared too much about what people think, so it didn't really bother me too much. But if you have kids that have this issue, you might want to go over it with them, and try to have that conversation of, you know, it doesn't matter what people think of you. If not for depth perception, for visibility reasons, you know, kids are mean. People are mean. They might get made fun of. So if you can have that conversation early, that's amazing. So some things that you can do with the nystagmus that we talked about the other day, my first go-to is patching. Okay? So unless it's both eyes, which even if it's both eyes, you're probably going to have one worse than the other. So, again, you patch, you cover the good eye. Okay? And you can use that atropine that I don't really care for also to blur that good eye. So essentially what that's doing is making your eye that's looking out here or looking in here come back to center, because it has to focus. It can't really focus over here. It can see, but it can't really focus and be your only source of vision, if that makes sense. So the patching is first. Glasses and contacts now, because everybody's vain now, let's just face it. And everybody wants contacts. They don't, I don't think, work as good, because you can't put a prism, to my knowledge. You might be able to, but I don't think you can, in contacts. So that same prism I was talking about with how they judge the degree, if you see those people with glasses that like when I didn't have lenses, I had those really thick glasses. They were probably like that. But mine started thin and curved outward, right? So that just is a prescription issue, right? If you see the people that have the opposite, you know, it's real thick out here and then it curves inward and then gets large again on the side, that's a prism. And I will tell you, from a medical standpoint, it is so freaking hard to read those glasses. You know, these glasses are bifocals. They're no-line bifocals. So you measure here and you measure here. Not too bad. A little harder with no line, but not too bad. Prisms, you have to like measure out here for a prescription here. I mean, not literally, but it's crazy. It's something I never ever enjoyed doing. So they actually talk about Botox, that you can inject Botox into the muscles. I personally am not a fan of Botox. I won't get it done for migraines, and I have really bad migraines. So it is definitely something you can look into, but not something that I'm going to preach. So the blurring, they have vision therapy too. I talked about low vision therapy the other day. So this vision therapy, it's teaching your brain and your eye to work together. So it can be done, usually it starts in the eye doctor's office. If your parent or you as the parent are committed to doing it at home, then they can get you the proper stuff and you can start doing it at home, just like you could physical therapy or occupational therapy or something like that. But it's trying to teach your brain, hey, we have to work together. We can't just be sending and receiving all of these mixed up messages because I don't know what's going on, right? And surgery. So in the surgery, what they do, depending on which way your eye turns, is which muscles they're going to work on. So let's say your eye turns outward. Okay? So this outward, they're going to loosen that muscle a little bit, and they're going to tighten this one. So it's going to pull it back. Okay? For kids with exotropia, the wall-eyed, almost never does that resolve itself. It really doesn't resolve itself in general. You need patching or glasses or something if it's bad. But the exotropia, for some reason, seems to be harder to get back under control. So it's almost always recommended that you go ahead and do the surgery. Like most things, it's definitely recommended that you go ahead and treat it as soon as you find out. And hopefully you heed my advice and you take your kid to the eye doctor immediately if you haven't already, because it's so, so important. Okay? So if you can catch it when they're 6 months old, they're going to have the surgery and forget about it. They're never going to know they had surgery until you told them. Okay? Yeah, they might cry, and when they cry, their tears might even be bloody. And yeah, as a parent, that might be really tough. But when you're thinking about the benefit of your child, they don't know they had it. Right? And I can tell you firsthand, and I know if Elizabeth's still in here, she'll tell you too, eye surgery is awful. Now, the ones that I've had and the ones that she's had probably are much worse. But it's still eye surgery. You know, most people don't even want an eyelash in their eye because it's awful. This one is a pretty quick recovery. Like for a kid, you can be back in school in about 2 days. They do go through it. I know most people are probably thinking they pull the whole eyeball out and then they start messing with it out on the table or something, but they don't. They don't do that, I don't think, in any eye surgery, but definitely not this one. They cut a slit and they go back through your eye and get to them that way. So then generally, it's more than one muscle that they're altering in some way, but it could just be one, maybe they're all okay, and so this one's just piled up over here, but this one needs help. This one will be okay when you tighten this one. Maybe. But usually you have to do more than one. Insurance, actually, I found this pretty interesting. Most people, especially when they have the noticeable, they would think that that would be cosmetic because of vanity and things like that. Well, it's not, because cosmetics, that's to improve your look. This is going to improve your function, okay? So it's considered reconstructive, okay? So that's great news, because your insurance, be it, I don't know about vision insurance. I think that would probably fall under medical insurance. But either way, it should be covered. And that, I think, is really, really good. Hey, Mom! So it also improves your social function, like making eye contact, because just like us from the outside looking at these people and saying, oh, I don't know which eye to look at, I don't know which one is looking at me, and feeling uncomfortable. Well, they feel, I guarantee you, even worse. They're trying to make eye contact with you. Let's say that you're in a business meeting and you're with your bosses. Well, you want to make eye contact because that's what you do. That's what you're taught to do. But you know that only one of those eyes is going to make eye contact. So when you get that surgery, it's like night and day, because now you can look at that person in the eye. You might not be able to continue to make the contact, just like I talked about the other day, but you should at least be able to shake their hand and make eye contact. You definitely, well, I shouldn't say definitely, you most likely will need more than one surgery. And the reason that is because there's sutures, there's stitches. And stitches have a lifespan. They don't say, oh my gosh, these stitches are going to last forever. That's just not the way they work. So when they go in there and they make these knots on the muscles, there's actually a new technique that is called an adjustable knot. And they're really only using it for adults because we have more of a subjective way to tell them if it's working. So what they do with the adjustable knot is they go in and they put the knot in, but they don't do it like extremely tight. So then the next morning when they come in for that post-op appointment, they say, okay, what is it that you can see now? And they do all the testing and this and that. So if it's still not perfect, they can go in and readjust it. Again, they come back the next day until it's right. Then when it's right, they go in and make that stitch permanent, or permanent for the lifespan of that stitch. So that is really, really neat, because in a kid, especially as their face and their eye develops, things are going to change, but you can't do that because a 6-month-old can't tell you, hey, everything's better. So if you get this as an adult, which you don't necessarily have to be born with it. That's a really great thing in the medical field to come across. It's outpatient surgery. They don't keep you. The surgery itself only lasts an hour or 2 hours unless they come across issues. One risk of the surgery is retinal detachment, and that is a risk in any type of eye surgery, especially those of us with Marfan's, because anytime you're messing with things inside your 1 inch, remember I told you your globe of your eye is only 1 inch thick, okay? So if you have all these instruments in there and you're messing with it, the risk of messing with that retina, the thin layer in the back of your eye, is huge. Okay, so that risk, of course, there's risks like bleeding and infection and vision loss, but retina detachment for us is a bigger worry. It's often seen in people with Down syndrome, and I think that maybe it's underrated in that sense because they just expect them to look a certain way, but it is actually strabismus. So maybe that doesn't get corrected because they attributed it to the Down syndrome. So that's just kind of a food for thought there. The amblyopia that I was talking about earlier, when that weak eye, when your brain completely forgets about it and it just stops using it, before you start patching or using glasses or whatever it is you're doing, it almost just turns off, if you will. It's called amblyopia. I went over that earlier. But it can be permanent. It might just be a really decreased, like you might have 2200 in your bad eye and 2050 in your good eye. And it might stay there, but the chances are very, very slim that it's going to stay there, because if you're not using something, just like your leg, if you're not, well, my hip, okay, if I'm not using those muscles, so they cannot build, okay, all they're doing is dystrophy, they're deteriorating, because I can't use them. So that's why people have to move my leg for me, so that these muscles are still making the movements. Same thing. If you don't use it, you lose it, right? That's me. I'm not positive on what's you, Elizabeth. So oftentimes in babies, it's called pseudostrabismus, and pseudo means fake. So fake strabismus, what do you mean it's fake? Like, are you just turning your eye in on purpose? No. With kids, especially kids that have like really flat bridges right here, they have extra skin in the inside, and it gives the illusion of them having cross-eyed. Sometimes they do, but that extra skin and things like that, it will give you the illusion. Okay, so that's definitely something to be on the lookout for. So I think that's probably about all I have. Again, 3D movies. When I read that article years ago, I was just in complete shock and awe. That is amazing. When people go to the movies, they go to the eye doctor. That's awesome, because some kids, they only go to the eye doctor when they're getting ready to go into kindergarten because it's a requirement. So if they went to see Avatar and got a really bad headache or got nauseous or couldn't see it, hey, why can't I see that, right? And they might have even went to their primary doctor and they said, oh, well, okay, that's a vision problem. Whatever the case may be, it's getting people in the door. It's getting people an exam. Hopefully, it is a dilated exam. I really don't even think that they should let you have an exam without dilation. That's just me. That's coming from a professional and a personal standpoint, because you can miss so much not being dilated. But at least you're being seen, right? Because there's so much you're going to miss without being seen.